Well, I hope everybody's enjoying their lunch. Our planning committee, we had a long discussion about what to do at lunch, and we made the decision that we were going to have a group of advocates tell their stories. I can tell you when we were writing the PCORI grant, I'd spent a bunch of time finding people who could serve as patient advocates, and we were having trouble, honestly, doing that, and I was at the EMSC all-funding meeting, and I ran into Paula Denslow. And Paula, who's up here on the stage, is a patient advocate, and we started talking, and pretty quick, her son, also an advocate who, I'll let him tell his story, joined us. We were able to get Kim Mears, who works with Jen Walthall, and then much later Mary Kay came to us saying, hey, you guys won this PCORI grant, and I'm really very interested, and we got her to join us as well. And so I'm just deeply honored to have them here. When we first met with them, they told their stories to us. And I found it so interesting and enjoyable that we decided as a planning group that we were going to have them present them to you. We thought this would be a good time to do it during lunch. I'm going to have them go through each of their stories, and then each of you who are our subcommittee chairs, if you will come up after the last story is told and join them in this panel, then we're going to have cards and you can write questions. Those will be brought to Paul and I, and we'll go through those and give questions to the panel. So that's how this is going to go. Of course, Rakesh is going to be our moderator for the questions, and I really appreciate him being willing to do that.
Thanks, Greg. I don't deserve applause. I'm not really doing anything here. So just to give you an idea, we talked through different ways to do this session. I think we probably could do this for like hours, honestly, to talk, if we wanted to. So a couple of things just before we start. I'm going to have each of the advocates introduce themselves and tell them about their stories. We'll probably do that for the first 20 to 25 minutes. During that time, in this age of Twitter and Facebook, what I have is index cards. Okay, they're on each of your tables. If you have questions that you want to have asked, of either the advocates, or we're going to have our subcommittee chairs join us after the advocates speak, please write them down. Teresa Liu will be coming around. Teresa, where are you? If you want to raise your hand. Teresa is the most overqualified person helping me here. She's an emergency physician in her own right. So, but thank you very much for taking the step down and doing this for us. She's going to gather up the cards. Kurt and Paul are going to filter through the questions, and we're not going to really get to all of them, obviously, but we'll select a few of them. We'll ask them. You can either direct them towards the advocates themselves or towards the subcommittee chairs, and I will try and kind of bounce around, between the two and see if we can have some good discussion about different systems-based issues that we're focusing on here. Just to introduce our panel over here, so starting from my left, Mary Kay Ballasiotes. Close. Sorry. Ballasiotes. Kim Mears, Troy Denslow, and Paula Mears. Troy Denslow and Paula Denslow will talk about each of their stories. So, Mary Kay, would you like to start? And we'll go from there.
Wow.
Or we can go the other way around.
That's okay. Are you guys okay with that? Go for it. All right. Well, we'll put that there. All right. So I am Mary Kay Ballasiotes, and is this on? Okay. I am the mother of 3 children, and I've also had the role of advocate for pediatric stroke for the past 20 years in various capacities. My youngest daughter suffered a prenatal stroke between 20 and 29 weeks gestation, and so my first role was as coordinator for her medical care. And then I started a support group in the Chicago area when we lived there, and currently I am the founder and executive director for the International Alliance for Pediatric Stroke. So what I've found over these 20 years is that most people are not aware that strokes can occur in babies, children, teens, and even before birth. Educating and increasing awareness of pediatric stroke in the community among parents, school nurses, first responders, pediatricians, and pediatric emergency physicians, to name a few, has been a key mission for our organization. But today, I'm here to share the story of 4-year-old Lelena James Fitzsimmons. And I've got a picture of her here, just because it helps if you have a face to go along with the story. I don't know if y'all can see that. Her parents called her Lainey. On May 7th, 2016, when Lainey was just 3.5 years old, she was at home taking a bath when her parents noticed her face was slightly drooping and she had mild slurred speech. It was very subtle, and her parents attributed it to being very tired. 2 weeks later, Lainey suddenly experienced slurred speech. One side of her face was drooping, as well as her mouth. She had trouble walking and using her limbs, and she complained that her hand hurt. Knowing something was terribly wrong, her parents called 911. The medics arrived at the house, assessed Lainey, and suggested she be taken to the ED. The doctors there suspected Lainey was having seizures and requested she be transported to another hospital for an overnight EEG. The results of the EEG showed seizure-like activity, and the doctors suggested she would need an MRI for better assessment. Since this was a Sunday morning and there was no sedation staff over the weekend, Lainey's parents were given the choice of keeping her in the hospital until Monday or taking her home and scheduling the MRI soon. They chose to take her home. There was no mention of stroke during either of these hospital visits. 3 days later, while Lainey was at home, she experienced the same symptoms: slurred speech, drooping mouth, trouble walking, but this time much more severe. Her father took a video of what they were seeing. Her parents then transported her to a different hospital ED for assessment. They showed the doctors and even the neurologist the video. A CT scan was done, and the results were normal. Again, the doctors at this third hospital diagnosed her symptoms as stemming from seizures and sent her home with a prescription for trileptal, which she took that evening. There was no mention of stroke. A week later, Lainey had her first neurology appointment, and her parents were told to keep her on the trileptal. The neurologist told them they could wait 3 months for the MRI to give Lainey a break from all that she had been through. Unfortunately, Lainey developed an allergic reaction to the trileptal. Her face swelled, her body was covered in a rash, and she had a high fever. The next day, now almost a month since Lainey had experienced her initial mild symptoms, she woke up and she was unable to stand, speak, eat, or drink. Her rash, fever, and swelling were still present, but less severe. For a second time, her parents called 911. The medics arrived and did not consider stroke. Instead, they administered epinephrine. Once she got to the hospital, she continued to have seizure-like episodes and was unable to stand or speak. Finally, the decision was made to transfer Lainey to a larger hospital that could do more testing. Lainey was transported to now her 4th hospital, where the doctors still did not think stroke. Instead, they noticed her blood pressure was high, so they gave her blood pressure-reducing meds. Lainey was given another overnight EEG, but she was unable to undergo an MRI because, once again, this happened on a weekend and there was no sedation staff available. Finally, on Monday, June 6, 2016, Lainey underwent an MRI where it was determined that she had suffered multiple strokes over the past month. During the next 9.5 months, Lainey struggled valiantly to regain some of her lost function, but she suffered more strokes and had 2 brain surgeries. Lelena James Fitzsimmons finally succumbed to the toll her strokes took on her tiny body, and she passed away on March 27th, 2017. Lainey's heartbreaking story epitomizes the consequences of the gap that exists in recognizing and treating acute strokes in children. Unfortunately, not only are strokes in children and teens being missed, we don't have established guidelines for treating strokes in children. Treatments such as clot retrieval devices and TPA have not been researched for efficacy in pediatrics. I am hopeful that moving forward we can address these critical gaps through the development of the pediatric research agenda so that children like Lainey can receive rapid diagnosis and treatment. Thank you.
Thank you, Mary Kay, and I think that highlights an adult condition that we're seeing in children, that really there's a gap there that we can try and bridge using the consensus amongst the folks here today in terms of education and care. Kim, I'd like to invite you to come up and tell your story too. Thank you.
Hello, I'm Kim Mears. I'm a family patient advocate. First and foremost, I'm a mom to 2 boys, 23, and Carter would be 12. Carter was my complex, critical child for years. But the day I'm going to speak about, we'd been home for about 4 days. He was on complete IV meds, TPN, total 24-hour care. He was in lots of pain, lots of nausea. This was after 6 weeks in the hospital, home 4 days. My husband and other son are out of town, and he experienced a seizure, which he'd only had 2 of those ever in his life. So I called 911. They got there, put him in the ambulance, and we were heading to our local children's hospital. He became unresponsive again, so they said protocol was to take him to the nearest hospital, even though that wasn't what he needed. So we went there. They were unable to intubate him, so he had to be bagged for an hour and a half to 2 hours before Lifeline got there. All of our PEDS protocols were not followed. You know, he was a HEMOT kid. They took a rectal temp, which could have been a problem because he did have bleeding issues. They started antibiotics that weren't his protocol. And just waiting an hour and a half to 2 hours watching your son struggle was very difficult. So luckily Lifeline got there. He got to his children's hospital, and he, recovered from that event. But I just really am passionate about making sure the children go to the correct hospital, even if it's a little further away, so that they can get the best care. Unfortunately, Carter did pass away about a month later due to his condition, but I'm here to advocate for children that don't have a voice.
Thank you, Kim. I think that actually summarizes why most of us are here today. Troy, I'd like to invite Troy to speak. So Troy, actually from a patient side, who was a patient, can really tell us a lot more about his story.
Yeah. Thank you. And thanks for being here. I guess those were 2 great stories. It's hard to compare to those. But we did, honored to be here. And Paul and Kurt, thanks for including us. Obviously, I'll thank my mom for giving me this opportunity. But we talked about it, I think we talked about it all, this opportunity for a variety of reasons. But we talked about it backstage. We look at everybody in this room, and even in the subcommittees and things that we've done together leading up to this, we're in awe of everybody. We think hero, miracle workers all day long. And I know most of the times the stories that we're sharing, as long as we all understand, and I think we all agree, can recognize and appreciate, we're just trying to get better and improve. And I think of my story, so not to waste too much time, but I think of my story, it's traumatic brain injury. It happened 20 years ago. I was in 9th grade, I was at school, and I was assaulted by another student, where punched in the back of the head, and then delirious walked into the wrong classroom, where he came up behind me and threw me into the wall, where my head hit the wall, the head hit the desk, and the head hit the floor. And I became unconscious, and other students in the classroom said that they noticed, seizure-like activity. It was, obviously I was not in the right state of mind to remember it clearly, but through all the different reports and friends and stories that have come through that, they wheeled me quickly down to the nurses' room in the school, and from that point forward, as EMTs, the ambulance and everything, it all began. That's where my memory starts of this whole situation. And I go from I go from nurse's room with the ambulance to where I start to hear my mom's voice, which was probably the first calming thing that I can remember, and she remembers it vividly. But to go from the ER through the ambulance, from the nurse's room in the ambulance to the ER, to where I saw 5 or 6 different doctors. And although you're out of it, you kind of remember that it was just so overwhelming. As a patient, as a 14-year-old kid, there's anxieties that are attached to that, anxieties that stay with you forever. I've had medication for some of the anxieties, and I don't attribute it directly to that, but I know that played a part. And in the subcommittees, and we talked a lot about this, is being informed. And as a patient, when you're in that situation and you're going through various tests and medical procedures, it's scary. And I think everybody in this room has a story of their own that they could tell. I just recall the lack of information that came to me and the anxiety that it created. I stayed overnight in the hospital. Things worked out wonderfully long term, but I think about it every day. I think about where are there opportunities in that story, in that experience, that could have resulted in something a little bit more of a positive response 5, 10, 20 years later. And I now as a parent, so I have a son who's 6 and a daughter who's 4, and I think of how far we've come from me going through that ER experience, seeing various doctors and medical professionals, and some wonderful things and some not so wonderful things. We took our 4-year-old, she split her head open, just a couple months ago, and my wife, she's a PA in the NICU at a children's hospital that's specialized, and we knew to drive 45 minutes further than the local hospital that was there. We drove that much further because we knew the experience and the care that we were going to get at that particular hospital was going to be a little bit more special, even for a cut across the forehead, which was very deep. The child life specialist that was there, and from me sitting back as a father and reflecting on my most traumatic experience potentially as a child, going through the ER, going through the experience with her, and watching this guy, Josh, who we know by name and I'll never forget, and the way that he explains that the thread of the sutures was Princess Elsa's braids, and how she got all these stitches across her forehead and didn't even shed a tear. I know we've come a really long way in the last 20 years, and to be able to be a voice here this week, I just think there's the biggest highlight that came out of that experience, from my experience 20 years ago, is to see that I don't believe we have to leave or bypass a hospital that's local in order to get that type of care from somewhere that's specialized. So those who do it really, really well, do it really, really well. And those who don't, there's just a massive opportunity to help coach them up and lift them up, even in a little bit, to be able to have that same experience that my daughter at 4 had that I didn't have 20 years ago. And I know conferences and things have happened, and people have worked together to kind of get to that point to where we are today. Now we're looking at the next 10 years. And to be able to be a voice here today and just to be able to share, and hopefully everybody can ask questions. But I think everybody in this room has been a patient and can tell their own story. But since you guys are all literally the miracle workers, it's just we're in awe of everything that you can do, trying to be all things to all people at all times, and prioritize a diagnosis and work towards solving the problem or the riddle that's there at the patient, but also trying to enhance and elevate this experience for the patient, which is much more of a personal and an emotional experience. It's really difficult to do, but we think we'll hopefully be able to help everybody achieve that, for the next 10 years, and at least capture that vision from a patient's perspective to get to that goal. So thank you for letting us be here.
Thank you, Troy. That was tremendous, and thank you so much for sharing. Just as a reminder before we have Paula speak is that the index cards are on your each of your tables. If you have questions, please fill them out. After Paula's done, we'll have our subcommittee chairs come up, and then we'll start the question and answer session. So, Paula, thank you.
Good morning. It's probably afternoon by now. First and foremost, thank you. Thank you, each and every one of you. I get very emotional because I proudly wear the hat of mom. I'm a program director. I work very closely with my state's EMSC program coordinator, and I am an unbelievable advocate, not only for my family, but I am your advocate. And this is an extraordinary opportunity to share with you not only our stories, but to help guide you in creating this research agenda for me personally in the brain injury world, which really has had an extraordinary experience and outcome. So Troy shared a little bit of his story from his perspective. From my perch, it really came across a little bit differently. I want to also say that I'm a very proud mother of 3 children, and 2 of my sons sustained brain injuries. When Troy was injured, I can still hear and almost sense, 22 years ago this fall, the calm within the chaos that our EMS providers at the school shared with me. There was that one-on-one eye contact, very slow and deliberate with his information, and I clearly understood the severity of any one of the blows to his head, that any one of those could have killed him. He also calmly told me it was a horrific thunderstorm on a Wednesday afternoon, and he said, turn your lights on and stay close. We got this. We'll see you there. I said, okay. Off they went. I'm going to fast forward a little bit and share a little bit more because of what Troy didn't say was that within the next 5 weeks, he had 2 more visits back to that same ED. We saw the same medical team when we went in, just by luck. And mind you, they're looking at me now with raised eyebrows, but it was all up and up. The second time Troy was injured, again at school, but not by assault, by just kids being kids. They were tossing a pumpkin around the classroom, and it deflected off of somebody's hand and landed on his head. The third time was because he was with friends, and his buddy turned around, and an elbow went to his head. The reason I took him back the 2 additional times is because the extreme headaches. Uncontrollable headaches. His pupils were different, and the fatigue was there. So all of that being said, we left the hospital. We teamed up literally with our primary care physician who helped guide us through post-concussive syndrome. Troy went back to school immediately, but due to cognitive fatigue and headaches, he was out of school from mid-November through that following February. He gradually returned to school, 1 class period at a time, and he never went back to school full-time till the last marking period of his senior year in high school. We had round-the-clock supports and help. He couldn't retain the information, so what he would learn in 10 minutes, we had to reteach him an hour later. So as you can see, he's had extraordinary amounts of supports from the minute the EMS provider wrapped his heart around mine and held my hand in his, and we went off to the hospital through all these years. My second son, Andy, 6 years later, was in a motor vehicle collision. Totaled the car. He drove an old an old Volvo, sorry, that was designed for the engine to drop down and fall under the passenger portion of the car. He did. Andy was treated at a local hospital. He had the strap mark from the seatbelt and an abrasion on his chin where they think is where he hit the seatbelt. Months went by, and my husband and I started realizing that Andy was different. His mood swings were different. One of the glitches that we encountered is that Andy's age, when Troy was injured, he was 14. I could lead that horse to water and make him drink. I couldn't do that with Andy because he was on the verge of turning 18, and there was a big part of what we thought was his senioritis. Anyhow, what had happened over the trajectory for Andy as not being properly identified and diagnosed as having that brain injury led for years of a cascade of events of lifestyle changes. So what I bring to you today is, as my questions have evolved over many years, and through my professional work, I wasn't angry with any of my care team, whether it was a healthcare provider or an educator or a community service provider. But what I really realized, what I could do better was to help get the tools that each of you need to make better decisions so that others wouldn't have a shorter long-term possible negative impact. I think for brain injury, education and awareness is the key. And I am so grateful to each and every one of you. The outcome could have been very different 22 years ago. And I just thank you for this opportunity. But I really want you to hear my heart, look in my eyes, and I thank each and every one of you in this building for what you do each day for others, and for those that may never have the pleasure of meeting you, but what your research is going to do for our future of our kids. So thank you.
Well, thank you, Paula. So I'd like to take a second for our subcommittee chairs to come join us up on the stage. And in the meantime, if you have questions, if you want to hold up your index card for me, Teresa will come and pick those up for you, and we will begin the question and answer. So, and I'll introduce the subcommittee chairs in a second. If you guys just want to sit here. Just to make sure that's working. Okay, perfect. What's that? No, I'm going to read it. Just have a seat. So I think the thought here is that our subcommittee chairs will be representatives for each of the different aspects of this conference, from workforce, education, research, and if you have questions that may either pertain to the advocate or a particular topic that could be best answered by one of the subcommittee chairs, we'll direct it towards them. So do we have any questions yet? If not, I can start. And I think what we'll do is, after we do the cards and some of the structured questions, I'll go around Phil Donahue style and just have people answer from the audience. So actually, I'll ask a question to start of Kim, if you don't mind. If you had any suggestions about how your child was cared for in a non-children's hospital. It's one of the groups that we have here, represented, and one of our goals is to bridge that care to make it equivalent, or as close to equivalent as we could. Do you have any suggestions for us as a PDM community that we could do to specifically to make that gap smaller?
I would say better education, so that even if the hospital's not seeing many children a day, a year, that they are able to follow pediatric protocols so that each child, no matter what hospital they're at, they get the best care.
And from the subcommittee standpoint, so Isabel, is that you from the non-children's? I mean, so what work do you think that we are doing again to close that gap?
Okay.
Thank you.
I'm Isabel Barata, and I think the first step is actually, and it was pointed out during the surveys, that we shouldn't refer to a non-children's hospital. I think we should refer to emergency departments that take care of children and work in a collaborative way, because I think being here and being together and really appreciating that there's so much knowledge being generated that it needs to be implemented at all levels, and to really also understand that the providers in those hospitals that have less resources, they want to take good care of children, and that is very important to understand that that is a partnership that is to take place between those hospitals and the hospitals that are generating a lot of the ideas and the research, and really look at everyone as being part of a collaborative team of providers that are taking care of pediatric patients in the best way that would be possible to have the best outcomes no matter what children present.
Hold on to that, Mike. Thank you, Isabel. Actually, my apologies. I should introduce the subcommittee chairs. Starting from my right, thank you, is Chris Merritt, who's representing education, workforce, sorry, excuse me. Maybelle Kou and Jean Klig, who are doing education. Kathleen Adelgais, whose office is right down the hall from me in Colorado, is representing EMS. And Isabel Barata from Hofstra University in Northwell for non-children's hospitals. And then Mike Stoner and Prashant Mahajan for research networks. So thank you. Okay, so here's a question from the audience, and this is for each of the advocates. So I'll start to my left and move across. So what is the one thing regarding care to acutely ill and injured children you would wish we'd figure out in terms of setting our agenda? Not to put you on the spot.
Well, yeah, recognition of what's going on in these kids. I mean, if a 70-year-old woman had walked into the emergency department with the same symptoms as Lelena, she would have been assessed and treated for stroke. So understand that these are not just little adults, but they have the same symptoms, so it needs to be recognized and treated.
I would think every hospital would have immediate access to the child's records. Like, the number is the same wherever you go, so that the information is there.
Wow. Yeah, that's what I was going to say. I feel like I'm more of like the sensitivity piece and the long-lasting effects and impact it has on the child's life. It seems like that was really important to me and impacted me that way. And recognizing that while also realizing the directive is to diagnose and heal. So whether it's the sharing of information to help reduce or minimize the long-term impacts potentially, whether it's anxiety or whatever it may be, I think that adds to an overall better, healthier experience for the patient.
To me, there's several things that are lumped together. I find it, education to me really is the key, but communication is also that part of that that communication piece. How can we better provide tools to properly identify kids that come in, and do we look at the mechanism of injury, even though they present and look absolutely fine and hunky-dory? Do we educate? I think it's the education part from the EMS all the way through the healthcare team, but society, in my world, society needs to really understand what a concussion, how a concussion may impact that child's learning. Those of us in the brain injury world and the community organizations say that a lot of kids grow into their injury because it might not be seen immediately. So how can we educate our families, take the mystery out of it, and pull everybody together on properly recognizing not only injuries that happen to those in the sports world, but those that fall down a flight of steps or have a bookcase fall on them or something like that. But that's my thing, is the education across the board, and then work together. We wouldn't be here without the love and support of his medical team and the school team.
Thank you. Yeah, I mean, I think we're all here for you. That's actually what we should always remember. Here's a good question, and this is again for each of the advocates. So the power of the stories for advocacy is very clear. Do you have any recommendations for how to recruit family advocates in a way that is sensitive but relays the power of their story to bring change?
Thank you. That's a very, it's a meaningful question, which I appreciate. I think having time for you to really hear our stories and where we're coming from. I often, when I do, whether it's a very small audience or a big audience, or I'm just talking with my girlfriends, I lead from my heart. And when I know my healthcare providers understand where I'm coming from, that really reduces my blood pressure. I don't mean to be panicky, but when you're involved with all of this, you're not really sure how to take the next step. And I'm looking for you and for others for that sense of calm. But I think listening and then helping us be able to communicate what it is we're trying to meet your needs, to be an advocate.
Yeah, no, you're right.
Is she stealing all your answers?
Yeah, gosh, that's exactly what I was going to say. Yeah, I don't think you have to look far. I mean, and I hope I don't misinterpret the question, but I don't think you have to look very far. You could probably find somebody today that's coming through with their own experience. But, I mean, for me, somebody to have simply asked the question of, would you be interested in sharing your story, would make me feel really proud and honored. It's pretty simple. I don't think there would ever be any disrespect taken on the part of a patient. To be able to share their story and help others is really powerful and uplifting. And I think, I'm just thinking of my wife, you know, they do the NICU, and they have, you know, an annual summer picnic for the, you know, graduates of the NICU to come back, and they're, you know, 16, 17, 18, and to be able to see, okay, this baby was born at 24 weeks and now they are healthy and thriving at 8 or 10 is powerful. And I know they use that experience and that return, and sometimes they often come back every year for this event. I know they're almost patient advocates in themselves just by being there, but they've often asked and created groups within that event to be able to find ways to improve their overall the healthcare experience at that hospital and in that specific unit. So I don't think you have to look very far, but I think all patients would be very honored at the opportunity to share, as we are, I think, all 4 of us today.
I would have to agree with him, because as a parent, what's the thing you want to talk about the most? Your children. So, I mean, I was truly blessed to be asked by multiple of my son's doctors to be an advocate, to talk. So I think if you just ask us, even if the outcome for, as my child, wasn't what we expected, it's still a learning experience, and I still want to share his life.
I can tell you that these pediatric stroke parents want to share their story. We've got a database. This month is Stroke Awareness Month, so we're sharing stories every day from around the world of kids that have had strokes. Last year, our theme for May was Be Fast for Kids. So we had stories, I think 25 stories from kids whose diagnosis of stroke had been delayed. So all of these parents want to share. You just have to ask. But they're out there. The advocacy groups are probably where you want to start.
Thank you all. I think that we all agree that I think having the patient's opinions is so important. It's just, I think we on our side sometimes feel awkward about asking. So another question, again, for the advocates, and if any of the subcommittee chairs has something they'd like to add, please let me know, and I'm happy to hand you the mic. How do you feel collaboration between providers, educators, and researchers from various backgrounds could improve outcomes for our children?
I think that's the key. I think
you all don't have to answer, by the way, if you want to.
Well, they all have to collaborate, and that's one of the goals that we have, is to get everybody in a room together so that they can all talk. And the physicians learn from the patients learn from the physicians, the researchers are there to kind of get all of the information, and that's the key to moving ahead, is to get everybody together to move it forward.
I would agree. Everyone just has to communicate.
Yeah, I think that's why we're here this week, and feel honored that we're all included. Is I think clearly everyone here respects and admires what we have to say, and everyone truly wants to listen in order to improve and learn and get better. So I think just doing exactly what we're doing this week is, I don't want to say a huge start, because I imagine this has been happening for a long time, but certainly adding this patient advocate element is huge, huge, innovative.
That's a great word. My thoughts went to, obviously, talking with each other, and as we've been brought in, set the table and look around who's at the table. I look at it from who, when Troy was injured, who was in Troy's life. One, I needed the school. He was in 9th grade. I needed his medical professionals. But when we came to the table, that's not your normal cocktail party dinner table. We usually, so what I would encourage is when there are events, if it's a school-age child, invite the Department of Education to participate. Find out, my work in my state, I learned through my hospital folks that, just as an example, the term concussion means diddly, you know what, in the school setting. If a child were to need special education services or any specialized services regarding a traumatic brain injury, they have to have the word trauma, traumatic brain injury, not head injury, not concussion. So learning those cultural differences within organizations is really key. And that, my friends, starts with building relationships. But you have to first acknowledge that that would be a gap. And I'm hearing throughout the last few days that this is definitely something that you all are recognizing. So I applaud you. We applaud you all.
Great, thank you. Just as a reminder, if you have questions, please raise your hand with your card, and Teresa will come pick it up. This is actually a really interesting question. For most of us in the room, a lot of us are primary researchers, and what makes the world go round is money.
Yes.
And funding to do good quality research. So this question specifically is for the advocates. It says, how can you help us, meaning the PEM community, to secure funding to support high quality research, such as talking to legislation, for example?
I agree with what Mary Kay's suggestion was. We have to work within our state legislature and awareness, and that again is an educational factor. But I feel strongly of we have a small army. This is a small army of people trying to tackle something that is so much greater than what we could imagine. So you have to work within systems that are already there. You can improve that through your voice, through just being engaged, whether that's, whether it's with our state's departments of health or departments of education or early childhood intervention. These are all systems that are established and recognized. And I think for brain injury, we can also elicit friends within the CDC. That helps drive a lot of the missions. But I think work within state agencies and talk with your legislators. Set up those appointments long before we're in session. Can you tell what I've been doing this year?
It's hard to follow that one, Mom.
Get it to you again. We'll get it to you first next time.
Don't get me back, trust me.
It's I wish I had a great answer. I mean, in my opinion, and for what I do now, it always seems to be a grassroots effort, and but tapping into patients who have some type of an emotional attachment to a situation, a funding for a research potential, anytime there's a personal connection to a cause, magic happens, I guess is a nice way to say it, and people come together, and it's powerful. How you find it, it's all specific to whatever it is you're trying to do and to research and to create it, but to find somebody there to be your champion through it all is probably a great place to start. And since I'm in the golf industry, you can have as many golf tournaments as you like, and keep going there.
I think getting out of your comfort zone and doing what people ask of you to help them is a big one.
Well, funding is always an issue, but there are some groups that are really good at raising money, and we've been working with the NIH. We're trying to work with the CDC. The CDC just came out with the pediatric TBI congressional report, which is fabulous. So working at the legislative and at the government agencies is a start.
Oh, sure. Yeah, of course.
Sorry. Okay, anybody remember Norma Ray? One voice can make a difference, and I think when, as an advocate, as a mom, as a wife and mother, I think using my voice in a positive way, and it's hard when it's emotional, but being as positive but proactive moving forward, I think it's huge. But one voice, if we all did one thing to improve the quality of care towards the outcome of the health of our children, can make all the difference in the world. But it can start with one.
Well, thank you, and I think that you being here as a group collectively is going to help us, I think, motivate us to involve patients and advocates in terms of, you know, going to legislation, talking to them about our studies specifically, for example. And I've seen that more and more, is that, you know, using qualitative work and so forth, we're getting patients more involved with our research and how we want to affect outcomes. So another question here, and I think this is generally for anybody up here, specifically towards the advocates, if you have opinions though, please. How do we change the dynamic and create an environment where parents and patients are more empowered to share their knowledge?
Could you repeat that one more time?
Sure, and I think I'll repeat the question, Prashant, please. So how do we change the dynamic and create an environment where parents and patients are more empowered to share their knowledge?
So one of the thoughts could be, you know, using technology as a solution, and there is already this access to open notes and patient portals, but a couple of interesting research has come out from that perspective. So we need to figure this out, you know, how to use the patient portals optimally. And there have been an increasing number of patient responses, you know, as to the outcome of their conditions, which is sort of giving feedback to the providers. But an interesting study just came out is when the patients get access to their own test results, it just increases the level of anxiety, because now suddenly they have a test result which could be, say, abnormal, for instance, or they may not be able to recognize the context in which the study has to be interpreted. So it also opens out these opportunities for communication, but the communication, even though it's an open note or an e-portal, we may need to have to do some more work on how to, you know, optimally communicate on this bi-directional way.
Anybody else? Okay. All right, I think this is for the entire group up here, and this is a somewhat challenging question, but so given that the technical approach to individual problems are at least as diverse as the problems, can the panel discuss what you feel are the potential common solutions? I'll repeat it again, because I see some puzzled looks. So, given that the technical approach to individual problems are at least as diverse as the problems themselves, can the panel discuss what you feel are potential solutions, common solutions? You know, you were going to say I heard you mumbling, so I'm going to put you on.
Yeah, just that's yeah. I was just communication. I think we all hear communicating from doctor, nurse, whatever it may be, to patient medical care. A very common theme is just keep me informed, right? Whatever it is, and that's with anything in life. Whatever that information is, however long it's going to take. Having the information up front allows you to kind of set your own expectation and prepare for whatever that journey is ahead. So,
possibly creating a mechanism for follow-up care, whether it's within, I'm thinking it from an emergency department standpoint, but using technology. I know that there are a lot of physicians and a lot of that provide cell phone numbers. You know, text me if you have any questions, and I'm not saying that everybody do that. I'm saying if we can come up with a way that relieves stress. Sometimes if you know where the exit is, it takes a heck of a lot of stress away before you have to run out of the building. But so what I'm saying is if we know as a parent, if I knew that I could reach out and get some additional answers, like an answer man, but someone that I would know would have a real history of what we were just, the experience that we just lived, but to be able to communicate that. And I think using technology, a lot of folks in the rural areas can't get there. So
I think Maybelle wants to offer an insight.
Probably as a follow-on to what you said, Paula, using technology so this can be friend or foe. And I think that everyone here is aware of many outlets on the internet that provide resources to not only patients but also physicians. And the trick here is actually curating what is actually quality content. And steering people towards the valid best practices that are applicable in your situation. And I think that's one of the technologic challenges that could be addressed. But therein, because there is so much, it needs to be approached just in a very systematic manner, and that needs to be worked out.
Thank you. I think we only have a couple of minutes left, so I have one last question here, which I don't know if we want to go around the panel and ask them. This is very broad. So what would you change in the next 10 years? And I'm assuming pertaining to pediatric emergency medicine and outcomes in helping patients. So everybody can take maybe a couple seconds and think about it, and then maybe we can just, even starting with the subcommittee chairs, and go around. If you could pick one thing, yeah, I'm putting all of you on the spot. If there's, if there's something you could change in the next 10 years to really help close these gaps, which is why we're here in the first place, what would that be? Chris?
I think this is probably the beginning, or this is maybe a continuation of that. But I think hearing the stories that you've had to tell, and having conversations with patients and advocates and families to help us really define what the research questions ought to be, because I think sometimes, and we can probably all think of times when we've done this, where sort of research begets research, but maybe not in the direction that is either most needed or is really what our communities desire, our broader communities desire. And so hearing your stories, I think, will help us kind of, I think, define the directions that we had. So that's not really the answer to the question. But
Actually, it's a good answer. Thank you, Chris.
I'm going to speak with my simulationist hat on, so I do a lot of work with pediatric emergency education in the simulated environment. And I think if I could change one thing about the way we approach education and communication in particular, it is communication strategies around giving feedback, active listening, and gosh, I could quote a whole bunch of people here, but I won't in interest of time. But that would be my...
Active listening being a really key one, for sure.
So we're hearing the word education a lot, yet we don't really have a robust system for collaborations for education, a robust research network for education, which is part of what our subcommittee discussed. I think we realize that with this, what we could power is a whole lot that I've already mentioned. We can disseminate best practices in education, what really works. We can align core content across providers, within provider groups and across providers. And we can speed translation from research to bedside through best practices. Without it, I think we're going to continue to hear a lot of the struggles that we've talked about. And certainly there needs to be a lot of feedback from the patient experience back to that. There are so many pieces that would help not only build it, but help keep it robust. We got to get there.
Thank you.
I was really going to work hard to not say anything while I was up here.
Sorry, Kathleen.
I think, with my EMS hat on and from our breakout session and our discussion about where we want to be, unfortunately for pre-hospital care, we're a little behind in other advances, and particularly for pediatrics. And the issue that came up again and again is about data linkage. And I know from Nate's presentation earlier this morning, there's certainly challenges and issues with linking data, but at the same time having a better understanding of the trajectory of care and how that ultimately impacts outcomes is huge. From the initial interface with an EMS provider or a medical provider at the start, and how that has downstream effects is something that we really still need to understand. And the other thing in hearing your stories that I wonder, as I'm not knowledgeable enough about this, is the need for patients to be present at the table on many different venues, whether it's a study section for grant funding and other things, but even at the hospital boardroom. Because so many things that we actually can do to care for children is actually not decided by us as medical providers. It's decided at a much higher level for funding reasons and priorities for hospitals and other things, and patients who can be present and advocate for, like, well, we need child life even though you only see 10% of the patients in your ER are children. We need child life. You know, that's not going to happen unless patients get there and say we want that. So.
I was going to say pretty much what everyone has said. This lunch hour panel is about the power of collaboration. And I think this is truly illustrated here because we're hearing the voice of the patients and their families and the providers that take care of those patients. And I think the power of collaboration has to go beyond it's the patients, the families, and the contribution of all the providers, where you have a network of the researchers, the educators, where we have pediatric care at the center, and we're all working towards that objective as a team, as a collaboration, as a network, and I think that will be the power of collaboration.
Now I'm going to have to echo what's been said here and kind of emphasize on translation and getting acceptance. Hearing the story of you drive 45 minutes out of your way to get a simple laceration repaired because that local hospital doesn't have the information, doesn't have the buy-in. It's just, we're not in the right spot yet, but we're going in the right direction.
So from my perspective, I think we should emphasize that diagnosis is a dyad between the provider and the patient. So it is both of a verb and also of a noun. The process of arriving at a diagnosis and naming the diagnosis. And I think the second aspect is sharing the uncertainty, So the providers need to be less overconfident, while the patient should also recognize the concept of uncertainty at that point in time.
Okay, so this is where the waterworks comes. I so appreciate what everybody's saying. Active listening on all of our parts is really key. From a parent's perspective or a patient, I have to trust that the other person is hearing me. But to be able to be invited to sit on a board and things like that, I know myself, I don't take that invitation lightly. I did not take this invitation lightly, as Kurt would say. It's with great pride, but it's also, it shows your level of commitment to the patients that you're serving is to be able to do that, to invite us in. But I think active listening and really guiding each other to the next step of what we can do together.
Yeah, Maybelle, I was going to say active listening is spot on. I mean, we're all just humans in general, and as a patient coming into, I know I'm talking to an expert in the medical world, but I'm also talking to a human who I'm asking for help from. I'm looking at you as I need help. I'm in a position right now where I can't help myself. I'm looking to you for that help. And just the human interaction of, for those who are mindful in that moment and look you in the eye and just engage human to human is so much stronger and healthier than somebody who doesn't and just moves on because you're a number and you got to go, and realizing that there's so much else going on, and there's a million other patients that need help, many of which probably need faster help than I do, but you got to get me out of the way. That moment, it's just a moment of that human interaction that could make all the difference. And I think that's the next 10 years, and that's forever, and that's not just in the medical world. I think that's human interaction in general.
Well, I agree with everything that's been said, and that including the patients is really important. And I can tell you a quick story. When I had the support group up in Chicago, I would invite medical specialists to come and talk to our group. They donated their time, 2 hours on a Saturday morning, and they learned as much from the families as we learned from them. They weren't giving specific medical advice, but to hear their side of it, and they heard our side of it, that was a phenomenal workshop, basically, for these parents and the physicians. So it really wasn't hard to find physicians that donated their time, and we kept it going for like 6 years, and it was great. So just including the patients and communicating at all levels with all the three groups, and include researchers. We had researchers come too, but bringing everybody to the table to collaborate is pretty important.
Thank you very much. I think we probably have to end the session and move on to our breakouts. I wanted to thank all our subcommittee chairs for being up here and participating. Thank you very much to our advocates, Paula, Troy, Kim, and Mary Kay, for coming and telling their stories and helping motivate us to provide better care for our kids. Thanks to Teresa for collecting cards, and I'm honored that Kurt and Paul would have me up here to help participate in this session. Thank you so much.